It is critical that the dental assistant be positioned correctly in the dental assistant stool. This reduces fatigue, aids in visibility of the dental field, and makes it easier to access things needed in the dental procedure. The stool itself has simple and straightforward parts. It is designed to be comfortable and provide stability and mobility while working. The covering is made to be durable and can be disinfected easily between every patient. The abdominal bar can be adjusted to be a back support or an abdominal support. There is a foot bar at the base of the stool for the support of the feet. When the dental assistant sits on the seat, her head is about 4 to 6 inches taller than that of the dentist. Adjustments can be made with the height positioning lever under the seat. This allows for that improved visibility. The dental assistant will sit facing the patient's head with their hips and thighs parallel to the patient's shoulders, and the hips and thighs are also parallel to the floor. Good posture is important for the comfort and efficiency of the dental assistant, because sometimes the dental assistant will be in a fixed position in lengthy procedures. A mobile cart can then be positioned to hold various dental instruments and dental materials. When the dental assistant stool is positioned correctly, the dental assistant is ready for the smooth and efficient teamwork with the dentist. Basic instrument passing is very much a part of four-handed dentistry. So four-handed dentistry occurs when the dentist's two hands and the assistant's two hands are working together as a team, working on the patient. First of all, notice that my assistant is actually sitting about 5 inches taller than me, which is correct. The two-handed pass usually comes first, and then we can begin to pass an instrument for another. The assistant is going to hold out a pinky, take it, and place it in my hand. And she's going to actually make sure that I actually have it and I'm not going to drop it or mislead it anyway. Or she might decide to put out 2 fingers, the end 2 fingers, and do a two-handed take with the instrument. Notice when any instruments are being passed, they're being passed here in the transfer zone, which is over the left shoulder of the patient and under their chin. And instruments are never passed over the patient's face. And notice that our patient, for their own safety, is wearing safety glasses as well. Instruments are also passed in the proper orientation so that they face the arch in which the dentist is working. So if the dentist is working on the maxillary arch, the working end of the instrument is facing the maxillary arch. So of course, the dentist, you have to follow whatever instructions they want you to do as far as instrument passing. It can vary a little bit, but this is actually the basics of instrument passing and the proper orientation. The assistant continues to put the instruments back on the tray in the working order in which they were being used, with the most common instruments closest to her from left to right. And then when the dentist is done with the instruments, they hand them back, and the assistant again places the instruments in the proper order on the tray. So this is a summary of the basic instrument passing.
Air abrasion is new technology that allows dentists to remove decay using no needle, no drill. Instead of the drill, a fine stream of abrasive powder is used to spray away the decay. Teeth have grooves and pits on their biting surfaces. Air abrasion can aid in both prevention and treatment. Teeth can be checked for hidden decay by brushing on a decay-detecting solution. After washing off the solution, if any grooves are stained red, decay is present. Air abrasion is used to remove the decay. A tooth-colored filling is placed, finishing the procedure. All without the need for the drill or the needle. Are there other advantages to air abrasion? Yes. Because the stream of particles is so precise, a minimal amount of tooth is removed. For this reason, it is sometimes known as micro-air abrasion. Can air abrasion be used for all fillings? It cannot be used to remove old metal fillings or crowns. It is ideal for areas of limited decay and removing old tooth-colored fillings. Is air abrasion used for other purposes? Yes, it is used for preparing teeth for sealants, removal of stain from teeth, repairing broken teeth.
This accessory is the air drill, also known as the high-speed air handpiece, which should be oiled at the end of the day. To oil it, you unscrew the sleeve, and you will notice that it has two large holes, one larger than the other. The large one is the exhaust, the smaller one the air input. You only oil the air input because the oil goes into the motor. The other is the exhaust. If you oil it there, it will go into the unit, damaging the unit. So you take the straw, put it into the small hole all the way down, give it a good spritz, then you match up the holes on the sleeve, screw it back on, and you're finished.
to practicing suctioning on a co-student, the correct OSHA-approved 2-wipe disinfection method must be performed on the dental unit. If you are not sure of the correct method of disinfection of a dental unit, please review the opening wipe and barrier video. You do not need to disinfect the utility cart or any of its attachments. With clean hands, no gloves required, place the disposable barriers. Those needed for this procedure are the patient chair, the light handle on the dental assistant side of the chair only, the light switch, the HVE, the LVE suction devices, the air water syringe, and the patient chair control touchpad on the dental assistant side only. Next, wash your hands or use alcohol rub to clean your hands. Don gloves. Place air water tips into the syringes and suction tips onto the suction hose connectors. The HVE tip should be placed into the hose connector with the bevel of the tip open and facing up and in line with the suction device finger switch. The hole or slot on the HVE should be up to go into the patient's mouth. After seating your patient, provide them with protective eyewear and place their protective bib on. Now place the patient into a supine position and arrange your dental assisting chair in the correct position for the suctioning procedure. The assistant must again use alcohol rub and dome PPEs. They should be put on in the correct order, which is the gown first, then safety glasses, and mask. Use alcohol rub again, then don new gloves. The assistant can now be seated and pick up the HVE suction device in the right hand, holding it in a pen grasp or a thumb to nose grasp, and turn the switch to the on position with the right index finger. The air water syringe should be picked up and held in the left hand. With the suction device turned on, a 20-second flush of water from the syringe should be directed into the HVE suction tip. In addition, the assistant should practice an air water spray into the HVE suction tip. Turn light on and direct the light into the patient's mouth. To rinse a bad taste from the patient's mouth, the assistant should use the LVE suctioning device. Held in the right hand, the assistant places the LVE tip into the patient's mouth and activates an air water spray to rinse back and forth across the patient's tongue. Be careful not to place the LVE tip in the center of the tongue, as this may cause discomfort to the patient and may possibly cause them to gag. Lift the LVE and move it back and forth from one side of the mouth to the other to collect the water and saliva that will pool in these areas. Instruct the patient to keep their mouth open while you are performing this procedure. Next, the assistant will use the HVE tip to suction water from the patient's mouth in the posterior area. Holding the HVE suction device in the right hand using a pen grasp, make sure the bevel and switch are facing up so the switch can be turned on and off using the right index finger. When using this device, the bevel should always be held parallel to the tooth or teeth you are rinsing in all 4 quadrants. When suctioning the patient's left side, the bevel will always be parallel to the facial surface of the teeth. When suctioning the patient's right side, the bevel will always be parallel to the lingual side of the teeth. After a few seconds of rinsing, discontinue spraying the water and collect what has pooled in the corners of the patient's mouth. Again, avoid touching the middle or back areas of the patient's tongue. Use the air-water syringe tip to retract the cheeks, which will create a clear vision of the area and eliminate the tendencies to suction the soft tissues of the cheeks, lip, and tongue. Also be careful to avoid resting the suction tip on the patient's gum tissue or lips during a procedure. Be aware of where your suction tip is located at all times, as this can cause the patient great discomfort. When the dentist is preparing the tooth from the lingual aspect of the anterior area, position the HVE tip so that it is parallel to the facial surface and extends slightly beyond the incisal edge. When the dentist is preparing the tooth from the facial aspect of the anterior area, position the HVE tip so that it is parallel to the lingual surface and extends slightly beyond the incisal edge. Limited area rinsing is performed frequently throughout a procedure as debris accumulates during the preparation and restoration of a tooth. This rinsing must be accomplished quickly and efficiently, causing no delay in the procedure. This occurs mostly when the dentist exits the mouth and pauses for inspection. Suctioning is an important dental assisting skill that takes a lot of practice. Do not be discouraged if this procedure seems difficult and frustrating at first. With practice, you will become proficient in this skill.
Preparing, placing, and removing the dental dam. Review your tray setup, making sure you have the equipment and supplies required. Use the mouth mirror and the Explorer to examine the site where the dam is to be placed. It should be free of plaque and debris. Floss all contacts involved in placement of the dental dam. After using a template or stamp, mark on the dam the teeth to be isolated. Correctly punch the marked dam according to the teeth to be isolated. Be sure to use the correct size of punch hole for the specific tooth. To ease placement of the dam with tight contacts, lightly lubricate the holes undersurface of the dam with a water-soluble lubricant. Select the correct size of clamp. Secure the clamp by tying a ligature of dental tape on the bow of the clamp. Place the beaks of the rubber dam forceps into the holes of the clamp. Position the lingual jaws of the clamp first, then the facial jaws. Following placement, check to see if the clamp is stabilized on the tooth, and check for fit. Use cotton pliers to retrieve the ligature, so that it is exposed and easy to grasp if necessary. Transfer the dental dam to the site and stretch the punched hole for the anchor tooth over the clamp. Position the frame over the dam and slightly pull the dam, allowing it to hook onto the projections of the frame to ensure a smooth and stable fit. This will stabilize the dam and aid in locating the remaining punch holes for the teeth to be isolated. Using your index fingers, stretch the dam on the lingual and facial surfaces of the teeth, so that the dam slides through each contact area. With a piece of dental tape or waxed floss, floss through the contacts, pushing the dam below the proximal contacts of each tooth that is to be isolated. When removing floss, slide it through the contact facially rather than popping it back out. This will keep the dam in place. A ligature is placed to stabilize the dam at the opposite end of the anchor tooth. Invert or reverse the dam by gently stretching it near the cervix of the tooth. A black spoon, FP1, or beaver tail burnisher can be used to invert the edges of the dam. Inverting the dam creates a seal to prevent the leakage of saliva. Apply air from the air-water syringe to the tooth that is being inverted to help in turning the dam material under. When all punched holes are properly inverted, the dental dam application is complete. When removing the dental dam, slide your finger under the dam parallel to the arch and pull outward so you are stretching the holes away from the isolated teeth. Use the crown and bridge scissors to cut from hole to hole, creating one long cut. When all septa are cut, the dam is pulled to free the rubber from the interproximal space. Remove any ligatures at this time. Grasp the dental dam forceps and position the beaks into the holes of the clamp, and open the clamp by squeezing the handle. Gently remove the clamp from the tooth. Remove both the dam and the frame at one time, making sure to remove any dam material from the interproximal surfaces. Inspect the dam to ensure that the entire pattern of the torn septa of the dental dam has been removed. If a fragment of the dental dam is missing, use dental floss to check the corresponding interproximal area of the oral cavity.
Xedecaine topical anesthetic gel is indicated for anesthesia of surface tissue, making it appropriate for use pre-injection or during procedures which require only anesthesia of the surface tissue. The unique pump-top dispenser controls the amount of gel dispensed and eliminates cross-contamination of the contents. To dispense a bead of gel, place index and middle fingers on each side of the center orifice and depress the pump. A cotton tip applicator can then be swiped across the top of the pump to gather the gel for application. Tissues need not be dried prior to application of Xedecaine gel. Apply gel directly to the site where pain control is required. Because of its ointment-like consistency, the gel applies evenly and consistently and melts at body temperature to absorb quickly into the tissue. Onset of anesthesia is within 30 seconds, and duration is typically 30 to 60 minutes.
To load the harpoon syringe, retract the harpoon and insert the cartridge. The rubber stopper must be attached to the harpoon to allow for aspiration before anesthetic. Once the harpoon is securely engaged, attach a needle of correct gauge and length to the syringe. When the syringe is assembled, remove the needle cap and express a small volume of solution to ensure the needle has penetrated the cartridge diaphragm and that the plunger is not sticking to the inside of the cartridge.
To begin any injection, there are 3 essential components: the syringe, the needle, and the cartridge or carpule. The components of the syringe include the thumb ring, the finger grip, the syringe barrel, the piston with the harpoon, and the needle adapter. There are many different types of syringes, but today we will only be demonstrating the aspirating syringe. The components of the carpule include the rubber diaphragm, which is a semi-permeable membrane through which the needle penetrates, the aluminum cap, the neck, and the drug identifying band. And lastly, the stopper. Okay, one thing to always examine when looking at a carpule is the expiration date. Check to see if there's any bubbles. Large bubbles means that the anesthetic has been frozen and needs to be discarded. Damage or an extruded stopper. Okay, components of the needle include the cartridge penetration end, the syringe adapter, the hub, the shaft, the bevel, and the red cap. Alright, how to load a syringe. We've already done a few steps, but normally you would remove the syringe from a sterilized package, then retract the piston, Insert the cartridge. Engage the harpoon by gently pushing down on the thumb rings. Attach the needle. There are also two different types of needles, a short needle and a long needle. Casey is demonstrating a short needle. Remove the cap. And expel a few drops to make sure there's no leakage. When recapping the needle, there's two ways to do it. You must either do a one-handed scoop method or have a needle recapping device, which Casey has here.